Welcome, everyone. We're going to give it just a couple of minutes while all of those joining us are able to log in, and we'll start in just a few. Welcome, everyone. I'm Mallory Schwartzman, Director of Business Development at Maryland Addiction Recovery Center. Thank you for joining us for today's webinar on the topic Collaborative Care and Community Partnerships in Mental Health and Addiction Treatment. Before we begin, we have a couple of housekeeping items to review. First, as a reminder, we will be conducting this session in webinar format, meaning all participants will have their microphones muted. We will not be able to see or hear you. During the presentation, please utilize the Q&A or chat feature to ask any questions. Depending on the volume of questions, if we can't get to our question before the end of the hour, we will have someone from our team follow up with you directly. Also, today's presentation is eligible for 1 continuing education credit. We would like to thank our educational partner, CE Learning Systems, for assisting in providing these credits, co-sponsorship with the American Psychological Association. Please note that in order to receive your credits, you will need to complete the post-webinar evaluation. A link will be emailed to you directly after the presentation from ce-go.com. After finishing the evaluation, you will have immediate access to your certificate of completion. Today's presentation is brought to you by Encore Outpatient Services, a joint partnership between Care and Treatment Centers and Maryland Addiction Recovery Center. Encore Outpatient Services operates partial hospitalization programs, intensive outpatient, and general outpatient programs for substance use disorder and co-occurring disorders in Arlington, Virginia. Encore's experienced and credentialed staff collaborate to provide each client with a highly personalized health services to aid in entering recovery and reducing the symptoms of mental health conditions. Leading the team at Encore are Martha Racketts and Kim Reagan, who are today's presenters. Martha Racketts oversees administrative and clinical operations as the executive director at Encore. She brings more than a decade of experience in behavioral health across multiple populations and levels of care as a clinician, director, and executive. Martha has experience managing all facets of treatment operations, including policy and procedures, compliance, outreach and marketing, and human resources. As a clinician, Martha has experience with various client populations and levels of care, including individuals, couples, families, group therapy, psychoeducation, and teaching. She has extensive experience in training and working with couples and families, specifically in treating addiction and trauma. Kimberly Reagan is the clinical director of Encore and is also a licensed clinical social worker and certified substance abuse counselor in the state of Virginia. She has worked in substance abuse treatment for 13 years, initially as a clinician providing direct care to clients, and then transitioning to supervising both intensive outpatient and inpatient medical detox. She maintained a private practice from 2006 through 2012, where she focused on adults with both substance abuse and mental health issues. She has experience working with adolescents, young adults, and seniors in various settings, including the foster care system, university healthcare, primary healthcare, inpatient psychiatric, and home-based counseling services. She is specially trained in mindfulness-based cognitive therapy, cognitive behavioral therapy, DBT, and interpersonal psychotherapy. Thank you for joining us today, Martha and Kim.
Thanks, Bree, and thank you everybody that's here. I'm watching that number go up. It's kind of crazy. We really appreciate you being here. We are here to present on the importance of collaboration among professionals in behavioral health treating our patients. It's our view that when we increase, oops, we need to go back to the other side. There you go. It's our opinion that when we are, as professionals, able to cultivate and create relationships among ourselves and be able to share information about our patients, that it improves not only their experience, but their outcomes in treatment as well. So to start off, we thought we would talk a little bit about incident rates for mental health and substance abuse. I'm sure that many of you working in the field know they're pretty common. So according to the National Institute of Mental Health in 2019, 1 in 5 US adults was suffering from a mental illness. And 7 out of every 100, so 7% of US adults were suffering from a substance use disorder. In reading the literature, it was mentioned several times that about half of the people who suffer from a mental illness will at some point in their lifetime develop a substance use disorder, and vice versa. So that was kind of a crazy statistic to see that I hadn't seen before. So often these things happen together, which we call lots of different names: dual diagnosis, comorbidities, co-occurring disorders. But basically the implication with comorbidity is that the illnesses, mental health and substance use, are interacting. They're affecting the course and prognosis of both illnesses, and that the most effective forms of treatment are going to address both of the conditions. Next.
So in the literature, if you look at what kind of research there is on collaborative care, I think that we all anecdotally in our own real life practice settings understand that collaboration is a good thing, right? But when you actually go to see, well, what kind of evidence is there? What are the outcome studies on there? On this, in the literature, you're going to find the collaborative care model, right? So this is an actual, tested, well-established model, the collaborative care model, an integrated service model. That is based on Wagner's chronic disease model. So it's originally designed as a medical chronic disease model, but then was updated and adapted to include treating the chronic presentation of anxiety and depression, as well as now substance abuse and PTSD. So if you look in the academic literature, this is what you're going to find. So it's a very specific model. Like the expectation when they're being studied and fidelity is being tested is that you're following certain tenets of the collaborative care model, which usually involves multiple providers, medical and behavioral health specialists, all working together under the same company or agency umbrella and then being co-located. So when patients are coming in, they're screened in a certain way, communication is happening in a certain way, they're being monitored and assessed over time, all through this very controlled track of treatment. And so what the research shows is that this is extremely successful. It increases patient outcomes for all of those different presentations. It's more efficient, it's more cost effective, et cetera. And then the basic tenets are also around there. These pieces around professionalism, right? Not just all these people are co-located together and that they use the same systems, but they're also expected to be careful around responsibility. So who's treating which part of the patient system? There should be accountability and coordination, communication, cooperation, obviously, assertiveness and how each one of the providers is communicating with one another, autonomy and how they're practicing, mutual trust and respect. Next.
So as Martha and I were talking about this topic, we started looking at the codes of ethics across the different professional organizations that most of us are familiar with. And so Assuming that the common goal, as we look here, the collaboration, it's working with one another, cooperating, working jointly towards a common goal, right? And so the assumption is that the common goal is that we all want our patients to have good outcomes. We want successful treatment experiences for our patients. So collaborative care has actually been a part of our professional codes of ethics for a really long time. And so specifically the ones that we reviewed were the National Association of Social Workers, American Counseling Association, American Psychological Association, the American Association of Marriage and Family Therapists, and NADAC. And all of them agreed on the basics of collaborative care. Some stopped there, and then some went on in different directions. I would really encourage you to look at your own code of ethics after this presentation, just to see where you fall on this. I will say the two most thorough codes of ethics were NASW and NADAC. So those are worth a look as well. Next. So we conceptualized this idea of collaboration. As we dug in a little bit, we realized there were kind of two different ways that we as professionals are going to interface. The first is a transfer of care. So if a client is leaving my care and moving into somebody else's care, or I'm receiving them into my care. So this idea of transfer of care, we wanted to look at that a little bit more as far as like the code of ethics and how it applied. So we put it on this hierarchy, and we were thinking of this hierarchy as almost like Maslow's hierarchy of needs. So at the very bottom, you know, it's that basic need, right, of our clients. So very basically, we're not going to abandon our clients. At the minimum is we're going to provide them with a list of alternative providers. So all of the codes of ethics agreed on that point. And then next, we're going to, as we move up and we start to meet, you know, slightly higher needs of our clients, we're going to actually sit down with our clients and assist them in identifying potential providers. So we may not reach out and do the work, but we're going to assist the clients in doing that work. So again, then we step up the ladder, and at this point, we're going to try to obtain a release of information for the new provider that they've chosen, make contact with that new provider in a timely manner. So, you know, it needs to be around the time that that transfer of care is happening. And then we would then pass along the information that's relevant to continued care. And then what we felt like was best practice, where there were certain codes of ethics that really went into this idea of collaborating and passing information on, was encouraging clients to attend an appointment with a new provider before they ever leave your care. So they are meeting with a provider, there's an overlap with your services, the ability to collaborate with the new clinician is really stepped up, and the client has a better experience of transferring care because your knowledge as the previous provider is really passed on, and there's a smooth transition. Next. So the second conceptualization of the way that we will interface with each other is in this idea of shared care. So where two or more providers are providing care to a client at one time. And so in this same idea of the Maslow's hierarchy of needs, we started at the bottom at the most basic need. And so basically the client needs to have the providers providing the care they need, but those providers are allowing the client to be the conduit between providers. So the onus is really on the client to make sure the information is transferred. As we move up the ladder, we are then obtaining a release of information and making contact with the other providers that might be in that system with the client. We might exchange treatment planning, decide on whose role is what, and then we kind of go back to our silos and work separately. Again, as we increase the level of need that we're meeting, we will contact that provider, we'll have that initial exchange of treatment planning, and then we will have contact again whenever a significant change occurs. So there might be a relapse, there might be an increase in intensity of treatment, the client might be discharging. So that we would hit, you know, the other providers and exchange information only in those times of crisis. So stepping up to this idea of like the self-actualized collaboration, we would have initial contact with providers who are sharing care. It would happen within 24 hours of us initiating services or that other provider initiating services. We would have a conversation about history and treatment planning. We would have a conversation about how to communicate moving forward. Or do we need to communicate weekly? Do we need to communicate more than that or less than that? And what's the best mode of communication? Are we emailing? Are we talking on the phone? Is it a text? And then we follow through and we maintain that connection. We allow our services to complement each other and enhance each other because we are communicating along the way and we know what each other is doing. The exchange of information is clinically relevant and as real time as possible. And then especially during times of crisis, that level of communication may even intensify further. Next. All right, so from the codes of ethics directly, this is pulled from all of those codes that I referenced earlier. There's certain characteristics that are really prescribed to be a part of this relationship. So this list on the left is the qualities that we should be bringing as providers into the collaborative relationships. And then the list on the right is really what we're doing. So what is the best practice? I think, most of us do this. It was interesting to see the 3/4 of the way down there, the avoid unwarranted negative criticism of colleagues was kind of different and new. And then also just developing and strengthening the respectful and collaborative relationships, really the spirit of all of us working together for the betterment of the client. Next.
So what we've talked about so far really encapsulates best practice, right? Like either the collaborative care model or using an integrative model or really trying to align with the code of ethics that most directly applies to you and how you practice. And we also know, right, that there's this abundance of research out there, right? So an article published in 2018 said there's more than 80 randomized controlled trials that have shown that collaborative care is more effective than usual care to improve quality of care processes, clinical outcomes, patient and provider experience, health disparities, and cost effectiveness, right? So this is just kind of like a no-brainer at this point. We're kind of overly saturated with this idea that we should be collaborating with each other. Everyone agrees, but then there's this, like ... like it's much easier said than done. In real world settings, what does this actually look like? If the resources isn't there, if the funding isn't there, if the organizational infrastructure isn't there, then it's actually quite complicated and maybe even confusing to do collaborative care. It's not as straightforward as all of the research would lead us to believe, or that our code of ethics would lead us to believe. Okay, next. So Sanchez, an article was posted in 2017 that actually now moves into this area of trying to get at barriers. So eliminating barriers or understanding what all of the barriers are to implementing collaborative care in real life settings. So there's these three big categories that have been identified. The first is clinical, we've got organizational, and then also financial. So clinical is patient level obstacles. So those which interfere with patient treatment and adherence to treatment or adherence to accepting a recommendation around collaborating. So this can look like just stigma that may exist, right, around a different level of care or working with a certain type of a provider, that the patient just is not comfortable working with a psychiatrist or not comfortable working with a substance abuse treatment provider. So it's things like that, right? It's really related to the patient, where they're at in the stage of change, their attitudes, their level of literacy on mental health, their adherence to what is being recommended. It could also look like patients refusing to sign ROIs or revoking ROIs, right? Like it's something that's happening with them that is creating a barrier, even if everyone else at the table of collaboration is very cooperative. It's something that the patient's doing that's creating their barriers to everyone else collaborating. Things on the organizational level, these are system level obstacles to the actual delivery of care. So even if the providers are on board and the patients are on board, there's something happening at the organizational level that is impeding this process. So a lot of people are going to say, I don't have time to do this. There's just not time in my schedule, or we don't have a dedicated person on staff to do this, or we have a shortage in the workforce around certain types of specialty providers. My caseload's too big, right? Or there's just, coordinating things, just the shifts that we have and coordinating, it's just something about something that's playing out on the organizational level that's creating the barrier.
For financial, this is also then related a bit to the organizational piece, because a lot of times collaboration is not billable, right? If it's not built into the frame in which your staff is staffed across your workflow or in your organization, then some people may wonder, right, if you're in private practice, you're not necessarily getting paid for collaboration. If that was previously a patient therapy hour, but now you're having to swap that out to do an hour-long collaboration call with another provider, like how is that getting paid for? It's also not very likely that insurance or other payers will reimburse for collaborative care sessions when the patient's not present. The last area, and this isn't included as a bullet point, but it's worth noting because it's not necessarily about the patient or the organization per se or finances, but it's more about the interdisciplinary nature that exists across providers, and that there sometimes is confusion, even though Kim said, like you should reach out and you should do a session before the discharge and you should get an ROI, and like it's not, everyone may have different protocols or expectations of what that looks like. And even if you're able to get another provider on the phone, you may not know exactly what to talk about. You may not know how frequently that should be happening. You may not know how to talk to someone who's trained on that model of therapy or someone who works in a treatment setting that you don't know anything about. So I think there's sometimes some ambiguity just when professionals are talking to other professionals, that they may not know exactly how to make that an effective call or actually coordinate care, even in the event that their schedules do match up. Okay, next. Okay, so we're going to switch gears and we're going to talk about implementation, right? Because that's where the rest of this conversation is going to go this afternoon, is around the implementation. What does this look like in real life settings? And how do we get from models, right? Like what works in theory to actually what can we do in real world settings? So we threw up the continuum of care here because it seems to be the easiest way to digest how integrated care may look in most treatment settings, right, across the country or in different regions. And it's from right all the way over on the left is our highest intensity of care. So right, basically a hospitalization. So an intensive inpatient or a detox. And then you move down, right? You've got a residential inpatient for a period of time, anywhere from 28 days to 3 months. You have partial hospitalization, which could be 2 to 4, 6 weeks long. Intensive outpatient or extended care programs can be 3 months to a year. And then you have sober living or a transitional or a safe living placement that could be anywhere from 6 weeks to a year or more. And then you have all of your outpatient providers, right? The big bulk of this can be therapists, this can be recovery coaches, it can be PCPs, psychiatric nurse practitioners, couples therapists, like you name it, right? Anyone who's going to be working from the outpatient provider perspective, right? And at that level of care. So this is classically what we see. But if you think about a real world setting or actually putting a patient through this kind of experience, I think we all know and we all agree that it's not this simple. And that it's not linear. It's not just a simple baton handoff from one level of care to the next. It's much more likely to be a bit more disconnected than this, and then also potentially more like integrated or more of a circle or like a web. So I'm going to hand it off to Kim to talk a bit about what a scenario like that may look like.
Next slide. So there's always the potential that balls get dropped, the baton doesn't make it as fast as the client, and that, there's a disconnect. So I'm sure we have all experienced, witnessed, even been a part of those types of experiences. And obviously there's, many, many opportunities along that long linear continuum of care to have breakdowns. So we wanted to look at it like this, where there's a lot of space. These are the providers that are actually touching a client, the detox doctor, the residential house manager, the PHP art therapist, on and on. And these people are actually sitting in front of a client and they're gathering a lot of information. Patients show up very differently for different practitioners and across different levels of care. And so within this system, there's a lot of knowledge that a patient has shared with us. And it's just sort of sitting in this system. And so if we don't successfully collaborate with one another, that information gets lost in the system. And we don't, allow that client then to grow and to experience those clinical gains and that recovery. And they actually will find themselves having to restart with each person that they sit in front of and start from square one and move forward, reintroducing, and then maybe even making the same, hitting the same milestones that they've hit previously. Next. So we were interested in kind of taking it to the streets and understanding in real life what a successful collaboration looks like and what that experience is like. So we had some really gracious providers who took the time to sit down and answer some questions that Martha and I had about their experiences of successful collaboration and what that looked like. And so I'm going to let Martha start off at the very top there with the detox.
So we're going to go, one square at a time, all the way around the circle, and give you all a bit of the perspective of these providers that we work really frequently with and really well with. And I also wanted to just point out how this is laid out, right? Kind of what this is visually representing. Obviously, this is no longer linear, right? Because our experience is that there may be handoffs that happen back and forth, but there are also a few providers on here that aren't just doing transfers, like Kim was talking about earlier. They're providing shared care. So they're all simultaneously working with one patient or their family for an extended period of time, not just for a warm handoff between providers, but across providers all at once, right? Simultaneous shared care. And so this is a much more accurate representation of what that will look like. But it also visually represents that they're all closely located with one another. They're all mapping around, the patient and the family's experience. And they can also move in and out of how closely integrated they are with the patient's care at that point in time. And so we're going to point out as we go how that may make a difference in how each one of these providers works with the patient and what their personal or professional needs are around collaboration. Okay, because some people stay integrated the whole time, whereas some others kind of move in and out of the continuum as time moves on. Okay, so the first provider that we talked to is a Novo Detox. This is a detox center that's located in Pennsylvania. And I reached out and talked to their executive director, Molly Ashcroft, about the Detox Experience, which is, there's going to be some similarities for inpatient hospitalizations, because what we're looking at is a high intensity stabilization, high level of acuity service that's being provided, right? The lengths of stay are short, but the acuity of the patient is high. So what is really unique and what I learned about the detox experience and what it's like and what their expectations are in working with other providers is that it's very quick, right? It's quick. There's a high level for efficiency. There's a high expectation of responsiveness from referrents as well as the referrals out. And they are a very fast, quick moving machine in detox facilities. So they look for creative ways to get people on the phone, to find the best way to get someone to be responsive. They're calling people, they're texting people, right? As opposed to other providers may do things like send out an email and wait 2 days to hear back, right? In this high level, the high intensity level of care with the shorter lengths of stay, right? Like detoxes can be anywhere from like 3 days to 10 days, right? They don't have time. They need to get an aftercare plan together, the referral picked out and coordinated with multiple days left in the length of stay. So their window of time is very short to do extremely high quality assessments, coordination of care with the referrals or the referrals out, and then to actually then have that warm handoff on the back end. So if you're working with a detox facility, right, the expectation is that you be very available, available to answer the phone, available to get on a conference call, available to provide all of that information very quickly, even from the pre-admission stage, right? They're not waiting for an admission to happen and then waiting a whole day before they reach out to someone to get information. It's happening very, very quick right from the very beginning. So that's the, kind of what we heard about best practice from working with a detox facility. The next partner that we reached out to was Kelsey Hatt. She's a continuing care specialist at Karen, and she's in their young men's program. And we also work with them quite often to go from the residential level of care to where we're at with Encore for the intensive outpatient. So what I heard from Kelsey, kind of the big takeaway from her position, because she's navigating that, like, the tricky transition of going from residential to going to an outpatient provider, or for that long-term aftercare, is that the quality of the handoff needs to be extremely high, right? Because of the challenges and all of the barriers that people throw up in the process of trying to go from one level of care to the next, right? From the residential to outpatient jump. So she is very conscientious about communicating what the ASAM criteria are, communicating what the clinical therapist has given as the level of care recommendation on the way out. So she's educating everybody on ASAM. She's providing all of that information verbally and writing. She's over communicating it, right, to really like seal the deal on the way out. The recommendation, this huge amount of information that the clinical team has discerned in this residential stay, actually makes it to the next provider, right? It's like this huge front-loaded knowledge transfer that Kelsey talked about that makes the transfer more likely to happen. And then she also talked quite a bit about making sure that the aftercare plan and the aftercare provider is of very high quality, of course, but also that it's going to be a long-term, good, realistic fit for the client, right? To not just put something on an aftercare plan, do the handoff, but everyone's pretty convinced that it's not going to go. So she talked a lot about, the residential team is very, they're highly motivated to make sure that where the patient goes next is a really good long-term, and then it's also going to be a very successful fit for that patient, right? They're really invested after spending all this clinical time with them at the residential level of care that it then makes it over. So that's what Kelsey talked about from the perspective of the residential clinical team as they are discharging out. Okay, so we're going to move on to Recovery Care Partner. So Recovery Care Partner is an outpatient company that's located in the Mid-Atlantic region in DC, and they have on staff all types and varieties of recovery experts. So they have interventionists, they have recovery coaches, they have academic specialists, they have therapists who work there, and what they are known for and what they're really good at is providing support before, during, and after any kind of clinical treatment, right, for substance abuse or people in recovery. And they are very good at moving in and out, right? If you imagine one of these shapes kind of floating in, floating out, floating closer to the middle, right? Like they're really there for everything. But they are very good, as I talked to Dawn Sloan, their founder, about knowing what their role is, right? Being very flexible, being very supportive, as a patient is moving through the treatment experience or moving through the continuum, right? Because they can hop in and they can do family education, they can hop in and do an intervention, or in that, a few slides ago when there was the precarious tightrope walk, right? Someone falls off the tightrope, right? Recovery Care Partner is who you're calling in, right? So they can swoop in, they can be on the phone, they're there in a crisis, they're there to provide basically the support in the gaps. And they're accessible however you need for them to be, right? However it makes sense based on where that patient is in time. So this is another good example of the linear model doesn't quite work, because an example like recovery care partner, they can move in, they can move out, they're kind of all present and all knowing, their staff are in the continuum of care experience. All right, Kim.
All right. So continuing around that circle, we have the Encore Outpatient, which we represent, and that is a partial hospitalization, intensive outpatient, and general outpatient levels of care. So we kind of catch this, this clients coming out of residential, coming out of detox, stepping up from private practice. So we have patients coming at us from all angles. And so it's interesting us kind of being situated on a circle where we are, because we're kind of this catch-all for information and for also disseminating information. We are a longer-term provider than, a 30-day, a 60-day, or even a 10-day program. So for us, we're going to participate not only in transfers of care, but also shared care. And so it's really important to receive timely information when a patient is transferring into our care, have that high quality transfer of knowledge. Very thorough information is critical for us, because we are providing multiple levels of care, and we need to be able to determine that level of care quickly before the patient actually steps into that level. So we gather information from multiple sources. So if a patient has come from a detox, gone to a residential, working with a sober coach, they have an outside private clinician, and then they're living in sober living. So all of these entities may interact with us. And so we are, working hard to maintain that communication, that collaboration, to make sure that this patient's experience is worthwhile and successful. When we are transferring a client out of our care, depending on the complexity of the case, we may actually initiate contact with the receiving provider, even 30 days before the patient is actually leaving our care, to ensure that smooth transition where there's this overlap and this shared care going on. There are also times when we are working with a private clinician and a sober living. That's actually often where we're trying to collaborate with them and provide that real-time information on our clinical end of what our program is doing, and then receive the information from them about what's happening when they're in their hands. Which actually then brings me around to Palisade House. So we spoke to Christian D'Avera, who is one of the founders of Palisade House, about their experience within this collaborative care model and how that works for them. They are a sober living, transitional living. Their program is 3-tiered. It's 3 to 3 months at a minimum, I believe. And they are working hard to transition patients out of sober living and into their lives again, and increase independence and functionality. So they are pretty much with these patients whenever they're not with another provider. So they have a lot of information. They're there when patients are, a relationship ends, they have a fight with a parent or a spouse, or they lose a job. So they're really there and gather a lot of information. They are dependent very much on the clinical information and how, receiving that in a timely manner. If a patient comes to care at IOP and has a breakdown in group and then goes back to sober living, it's important for that real-time exchange of information to happen, for them to be able to then support that patient in whatever it is that they're going through. In talking about some of the barriers that might come up, I know one of the things mentioned was just like making sure that patients are prepared when they come into sober living for what that means, because they're very different from, say, Oxford House, where there really isn't a ton of structure except what the patient themselves brings in, but that this is a staffed and very supportive living environment. And so just decreasing the level, there's already probably some resistance and some reservation and anxiety around moving into a sober living. So minimizing those surprises was something that was helpful for them, along with, the theme all the way around the circle is very open, very timely, and very transparent communication. So then as we move around again, Susan Berlin was the private practice clinician that sat down with us, and she has a unique perspective as well, because she, again, similar to the intensive outpatient PHP providers, she's a longer term person, and she actually may be involved with the client all the way through this circle and then beyond. And so due to that, being her involvement being more long-term in nature, she values very much that open, honest, very timely, very clinically relevant communication, but also as a, busy private practice clinician, scheduling and time are an issue. So workarounds that she's found that work are, emailing, having regular emails, that way being able to email back, or to, to deal with things on off hours and not have to play phone tag with one another. She said she valued very much the quickness of response, the accessibility of providers at all levels of this care, of being able to very quickly get a hold of somebody to help transition a client seamlessly through this continuum. And then also that shared care of regular communication, maybe even working with a client through, on a weekly basis throughout this entire continuum, where she's able to maintain that rapport, be involved real time as things happen clinically, so that she can then receive and continue that care later without any of, she may be left where nobody else is involved in this client's care. Next. All right, so kind of to summarize some of the solutions identified through these conversations, and then also just sort of through the research, and then through the codes of ethics. So everybody really echoed the idea of very responsive, very timely responses, flexibility in coordinating schedules, and then just maintaining ongoing contact and check-ins, whatever is agreed upon in the beginning, and maintaining that, being open to that changing in times of crisis. There might be a need to have more attention. Excuse me. Focused attention during transfers. So when transfers of cares are happening, that front load of information was a theme, providers kind of knowing up ahead what's coming into their program, into their care, so that they can really be prepared and make sure that that patient has the best experience as they admit into that program or that clinician's care. Bridging interventions. So allowing to overlap in care, and so two clinicians working together with the goal of handing the patient off to one of those, and that's also the warm handoffs. Organizationally, some solutions that were talked about were just creating positions for specifically for intake specialists and for discharge specialists, whose job focus would be this: collaborating with other professionals and making sure that patients move through this continuum in a organized way, and in a high level transfer of knowledge and responsibility. Integrated treatment teams. So having, like at Encore, we have contractors for nutrition, we have contractors for psychiatry. We work with academic coaches and career coaches, and those people are at the table during clinical rounds and during treatment team meetings. They're integrated into the program and even co-located in the office where they're going to meet with the patients in order to really expand that communication and allow everybody to be on the same page. And then also creating formal or informal partnerships with other agencies or organizations that share a similar philosophy to you, and that you can build that relationship and start to really collaborate well and improve patient experiences. And then just sort of on the personal level, I think being willing to explore each other, explore the different points on that circle, and understand the points of view of each of those. Also exploring the models that are being used by different clinicians, so that you can develop this shared language of understanding when somebody references 12-step, that you know what they're talking about, or the different philosophies that go through the different providers. And then taking the time and putting the effort into building the rapport with other professionals, building that level of trust where you can just shoot a text off or make a phone call and you know it's going to be handled on the other end. And then just human connection, which I know is something that's been lacking with COVID, but increasing that human connection with the other provider. So it's not just a website or an email address, but it's a person that you're talking to and you have this connection with. Next.
Yeah, and I just wanted to speak to the person connection as well before we move on to technology, right? Like the impersonal. A lot of the providers that we talked to talked about the personal element to what makes it work, right? That it's outside of the logistics, the protocols, the best practice. It's actually like knowing people on a personal level. It's this idea of having like, I trust them, they're known to me, I can text them when I need them, I know what's going on in their personal life. I mean, not to blur the boundaries, but when we ask like what makes a really good partnership for you and what makes collaboration on really tricky or complex cases work and successful, a lot of people said, you know, it's because I actually know and trust the people who I'm working with. That's not like just this unknown entity that I'm setting medical records to. I can really like get into the thick of it with another provider and really just lean into our personal relationship and know that this patient is going to be safe in their hands. So it's, you know, it's really important to slow down, right? And it's also, you know, Kim and I were talking about this as being kind of a parallel process to the rapport building in the therapeutic relationship, right? Kind of before you get to business and you move right into, you know, treatment goals and interventions, like you really just need to slow down and build a relationship with someone. And it's absolutely going to be true in provider collaboration that you really know people and trust people, so that then, right, that parallel process can then move down through to the patient's experience in therapy as well. Okay. Okay, so let's switch gears and let's talk about the use of technology. So technology, obviously, you know, in all aspects of life, you know, like if there's a problem or a thing that we need to work on, right, there's an app for that, right? We use technology to make life easier, to make things more efficient. And of course, right, technology came up a lot as being one of the potential solutions. Like it is the solution or one of the solutions that people use when they're thinking about, well, I have all these barriers and how can I make this easier for myself? Obviously, you know, telemedicine, virtual therapy has been extremely accessible and offered extensively, right, across everywhere. This past year and a half. But there are specific collaborative care models that use telemedicine in order to be successful. So I've got there one citation for an example. But something else that I wanted to speak to about the use of technology is that technology is a lean form of communication, right? It doesn't come with voice inflection or facial expressions or all of the nonverbal and relational components that exist in a face-to-face or even like a Zoom interaction, right? I'm talking about like texting people, emailing people. It's very lean. And there's a lot to be guessed about in that communication. And so usually, right, what we know about technology and the use of computer-mediated communication and interpersonal relationships is that it can be successful, but usually you need a relationship with the person first, like an in-person, real or voice or something, right? Like you need to build up kind of a bulk of familiarity and trust with someone before you can just start like texting back and forth about a patient and what they need, or just sending like a dry email once a month, right? Like you may not trust the information that's in there. You may second guess what they just communicated to you. So usually, right, what we know to be true based on the research that's out there is that if you really want to lean into using really to using very efficient and quick forms of communication like texting people, you really need to make sure that you front loaded that relationship first in order for that to be successful. And then we also just wanted to speak to another creative solution that is coming up in different apps and EHR portals. It's shared portal access. So even if you're not all part of the same agency or the same company, there are still apps and portals out there that you can grant other providers access to. so that everyone can be, electronically observing and communicating and on the same page around treatment progress and treatment plans and communication. And one example of a company that we've been working with is called You Are Accountable. So that's worth looking into if you're interested in this shared portal access kind of a feature. All right, next.
So yeah, in summary, kind of the summary of everything is really around the relationship that we build as providers with one another. And so the quality, in the research, it talks about the quality of the relationship between the provider and the patient being very predictive of the success of the therapeutic outcomes. And we kind of qualitatively, there's no research to back this up, feel like the quality of the relationship between providers providing care is also going to affect the patient's experience and the patient's outcomes and success in treatment. And so we also felt like there was, there's a lot of different points of view around this like continuum circle that we have looked at, and misunderstandings and miscommunications are so easy to happen. And so, being able to participate in this process of feedback to each other, rather than this like, shut down and no more communication, that person, that's they're gone. We as providers, I feel it's incumbent to increase the competence and increase the high level care being given to our patients, and that it only improves everyone and allows access, increases access to care if we're able to talk to other providers about, hey, this didn't go well or this did go well, and to raise each other up. And so that's, something that we found throughout this literature review and conversations with providers. And then really just taking the time to educate yourself about the people in the system that you're working in, learning about their, their particular profession, their approaches, their modalities, their kind of, backgrounds, and being able to really take the time, like Martha said, slow down and get to know each other, and start to build that rapport and build that trust. You want to take that bullets?
Yeah, and I think just in conclusion, right, like what does that look like in real life settings, right, which is the whole theme of today. Like go outside of your own company, right? If you're in a big company, then make sure that you're collaborating across departments, across disciplines, like kind of get out of your silo or kind of your own little rhythm of working and reach out to other people who are trained in different ways or who have other credentials. But then also, right, get outside of your own organization, right? There's lots of networking groups that you can lean into. There's PLA organizations all over the country. You can find a interdisciplinary professional group or a place where people are getting cross-trained or meeting other types of providers. If you're interested in validated scales of measurement, there is a scale out there. It's the Interprofessional Collaborative Competency Attainment Scale. We're happy to send that over to you all if anyone wants to see it. And then also just doing trainings, right? Why not cross-train your entire team on something that would have only, technically been for the recovery coaching team, but you're actually going to have everybody on the team get trained in the same way, right? Because it increases the shared language, cohesion, and then obviously is going to, increase your ability to collaborate and have successful outcomes. So that is our presentation today. We really hope that was helpful to you all, depending on where you're at, at the table and what your perspective is. And we're going to let Mallory do our exit.
Wonderful. Thank you, Martha and Kim. We are now going to answer some of the questions that were submitted through the registration process. So the first one is, can you address the difficulties interfacing with multiple therapists on one family's case?
I guess I can start that. I think just the difficulty, the first thing that comes to mind is the one that we heard most often and read about most often is scheduling and time. When you're a therapist and you're working independently in private practice or even in a program, there's caseloads that are big. And a lot of times I know my own experience in private practice, you're scheduling people back to back to back and trying to, be all things and get people in. And so being able to fit that in when there's, 2, 3, 4 providers involved in coordinating all those schedules can be a huge barrier.
Martha, anything to add?
Yeah, I think that I would add, so in addition to the logistical piece is also just different modalities that are being used and different alliances with different patients in the family, right? And really being transparent about that, right? And kind of deciding if different modalities are being used to move through treatment, right? Like knowing what change means, like what's the change model that we can all create a shared umbrella around. And then also, how are we going to navigate the alliances and the cross alliances to make sure that we are advocating for change across the entire family system, as well as change for each one of the individuals. So you're probably going to have like a philosophical models discussion in addition to then tackling all of the logistical pieces of it. And it may take more than one conversation, right? I think that some practitioners have like one conference call and then they just go straight to email after that, right? Rather than having like, why don't we plan on talking like once every 3 weeks for 30 minutes and all of us get back on the phone and see where it's going. It's done kind of piecemeal, but then it ends up kind of falling, it falls off the rails over time. So, eliminating the barriers around the logistics, and then also having a really transparent conversation around your model of change and then how you're going to navigate, the system and your therapeutic alliances.
I think one thing to add there too is just that potential when there's multiple providers involved is the potential for splitting. Like one client gets some information, one provider gets other information. And if you don't have a good, relationship and a good rapport built with those providers, you can fall victim to believing or, assuming the worst is happening, and can create a rupture and just chaos within the system that doesn't need to be there if you've established good communication and relationship and rapport ahead of time.
Mm-hmm. Excellent. For the second question, what are your thoughts on the role of Lmsws in private practice to provide individual client case management?
So I don't think that we have Lmsws in Virginia, but I think they're called LSWs, so they're pre-licensed. And I think, as far as case management, obviously they're operating under supervision. So I'm not sure if, I think if somebody's dedicated to case management, kind of the conversation that we're having here is how important it would be to have a dedicated physician that can look at case management and really work through, the relationships with providers and transfer of knowledge. So I can't see it as a bad thing.
Martha, or should we go to the next question?
Oh, I was just going to comment that case management is actually part of the collaborative care model, right? Like, what is evidence-based as far as providing an effective collaboration? That's in there, right? It's one of the key components is that someone is able to do the case management and they're able to do the monitoring over time. So.
All right, and for our third and final question in this portion, what evidence suggests that collaborating across all social determinants of health improves the overall health outcomes of community members?
Yeah, I think, what was fascinating is that, Kim and I did a lot of like combing through the research and combing through the literature. And literally, if you just put in collaborative care models into like Google Scholar or into an EBSCO host or a JSTOR, like there's an abundance of research, right? It's not like there's this one study or this one meta-analysis. It's decades worth of evidence that is showing that doing collaborative care across social determinants, agencies, interprofessional, interdisciplinary collaboration is effective, right? It's kind of it's more the issue of the implementation, which is what the takeaway was from today. So the evidence is there that it works. It's more the how in your real world setting in the locality or the region that you're at with the providers that you most closely work with, like how are you all going to make that work to get most in alignment with best practice, which is very individualized to each provider's training and setting and the patients that they're working with. So the evidence is there. If you want our list of resources, or you want our list of citations and the research that we pulled from, that feel free to reach out and we can provide that to you.
And I think just experiential too, we can having been doing this for a long time, you can see the outcomes, and the care is so much higher quality when providers are talking and communicating, and there's the client is held in this safe container versus being the onus is on them to carry their own information.
Mm-hmm. Wonderful. Well, for sake of time, I know that a few live questions came in, and we will address those directly with those who submitted those questions after the presentation. So thank you again to Martha and Kim for your informative presentation, and to all of our attendees for joining us today. As a reminder, this presentation is eligible for 1 continuing education credit. Please keep an eye on your email. The link from ce-go.com will be sent directly to you for you to complete the evaluation. Before we close out today's session, I'd like to share an upcoming virtual event Karen will be hosting next month. The Karen Ocean Drive program in Florida will host a virtual open house on Tuesday, July 14th. This will provide a unique opportunity to meet the team, learn about their services, take a virtual tour inside their elegantly appointed facilities. You can register for this event at karen.org/virtual-open-house-series. I'll say that one more time for everybody that might be writing it down. So it is karen.org/virtual-open-house-series. Please reach out to your local regional resource director at any time for any additional information, resources in your area, or questions regarding admissions to any of the Karen programs. Additionally, please feel free to contact me, Mallory Schwartzman, at Maryland Addiction Recovery Center with any questions or inquiries about our program or services. And again, thank you all for joining us, and have a wonderful afternoon.
Thanks, everyone.
Thank you.